ನನಗೆ ಫರ್ಮ್ ನಾನು ಅತ್ತ ಸೈನ್ಸ್ ಜಸ್ಟ್ ವೆರಿ ಫರ್ಮ್ ದಿಕ್ಕಾನಿಗೆ ಬಲೆ ಬಲೆ ಅವನಂತೂ ಕೊಲ್ಲಿಕ್ಕೆ ಮೇಕಲ್ ಕಾಲೇಜಿನ
Start ಮಾಡೋಣ ಮೇಡಮ್. Yeah. Shall we start? President sir start ಮಾಡೋಣ್ರಿ. Savita ma'am, Anuradha ma'am. Shall we start?
Yeah, and 1 minute.
Another 5 minutes, Sanjana.
Not 5 minutes, ma'am. 1 minute. 7 sharp. We'll start.
Don't. We'll wait. We'll let some more join now.
ಸಂಜನಾ ಮೇಡಮ್. ಗುಲ್ಬರ್ಗಕ್ಕೆ ಯಾವಾಗ ಬರೋಣ ಅಂತೀರಿ?
ನೀವ್ ಯಾವಾಗಂದ್ರೆ ಅವಾಗ ಬರ್ರಿ ಸರ್. ಬರ್ರಿ ಸರಿ.
ಬರ್ತೀರಿ. 12 ಆದ್ಮೇಲೆ ಬರ್ತೀನಿ ಮೋಸ್ಟ್ಲಿ. 12 ಇದೆ ಬಿಜಾಪುರ. ಇಲ್ಲಿ ರೋಣಾಗಲ್ಲ ಪ್ರೋಗ್ರಾಮ್ ಇದಾವೆ.
ಎಲ್ಲಿ ಸರ್?
ರೋಣ IMA ರೋಣ ಗದಗ ಮತ್ತೆ ಹುಬ್ಳಿ ಇದೆ. ಎಲ್ಲ ಮುಗಿಸ್ಕೊಂಡು 12th I think 12th after 12th I will try to come to Gulbarga.
ಬನ್ನಿ ಸರ್.
Good evening, Venkatachalapati.
Namaste sir.
Good evening.
Sukumar.
Yeah. Venkatachalapati sir. Namaste sir. Sir, ಇವಾಗ ಕಾನ್ಫರೆನ್ಸ್ ಮಾಡೋಣ ಅಂತಿದ್ದೀರಲ್ಲ, ಅದ್ ಮಾಡ್ಬೇಕು ಅನ್ಕೊಂಡಿದೀವಲ್ಲ, ಅದನ್ನ ವರ್ಚುವಲ್ ಮಾಡೋದಾ ಅಥವಾ ಇದನ್ನ ಮಾಡ್ಬೇಕಾ ಸರ್? ಲೈವ್
ಮಾಡಬೇಕಾದ್ರೆ afterwards we can have small meeting. So you decide. You first just decide. And then we can take a call. How many people will be there if you do physically? That is important. So once you declare physical, then you should have good numbers, no?
Yeah. Hagalla, whether we can do at the current situation, sir?
We don't know, no. Still the third wave, the sword is still hanging. We don't know.
Okay, so shall we think of virtual only?
Virtual ಮಾಡ್ಬಿಡ್ತೀವಿ sir. We'll start
virtual because we are all in different corners.
Virtual and hybrid could be a possibility. Then if things can fall in line, then remote chances of physical meeting.
Yes sir.
I would encourage physical, but we don't know, no, suddenly if the government brings some regulation, then all our questions will go in vain.
So because for us to plan, first we'll think of virtual right now and we'll plan up, sir. So today we are thinking virtually of conducting a for that.
We can do everything on virtual platform. Whatever you want to do, prepare immediately. You can do that. Preparations should happen. So
yes, sir. Shall we keep in mid of September, sir? So
last week it don't know, madam.
When would it be ideal, sir, for us to keep the conference? Last week of September?
Yeah. September last week probably. But let me tell you, because we have got the state working committee clash, it could clash out. So prepare, then I'll let you know the dates.
Yes, sir, because
we can't keep 12th we have no cases.
Because for the speakers we have to ask, no sir, so we want the dates also. Adike, should it be on the third week of September or last week of September anta?
But SWC is more important, so that date we have to fix. Our date fix admele, then we can go ahead with the women doctors conference.
Right, sir.
Right, sir.
Okay. It's okay, ma'am. Later on. ಫಸ್ಟ್ ವೀಕ್ ಅಲ್ಲೇ ಹೇಳ್ಬಿಡಿ ಸರ್ ನೀವು ಯಾವಾಗ ಅಂತ
ಹಾ,
ಫಸ್ಟ್
ಹೇಳ್ತೀನಿ.
ಸರ್
we'll go ahead.
ಯಾಕಂದ್ರೆ ನಾವು ಎಲ್ಲ ಬೇಸ್ ಲೈನ್ ಅನ್ಕೊಂಡಿರ್ತೀವಿ ಸರ್ ಯಾರ್ಯಾರು ಸ್ಪೀಕರ್ಸ್ ಏನು ಅಂತ. ನೀವು ಡೇಟ್ಸ್ ಹೇಳಿದ್ರೆ ನಾವು ಆ ಡೇಟ್ಸ್ ಗೆ ಅವ್ರನ್ನ ಇದ್ ಮಾಡ್ಕೊಳ್ಳಿ.
You keep talking to the speakers, then you can once we fix the date, then you can let them know.
John,
Yes, sir.
ಇದ್ದೀರಾ?
Yeah.
ಸ್ಟಾರ್ಟ್ ಮಾಡೋಣ ಮೇಡಮ್.
Yeah.
Good evening, Dr.
Start
Good evening,
ಮಾಡಿ.
Dr. Anuradha.
Good evening, Dr. Shivakumar.
Yeah.
John ಅವ್ರು
Hi,
ಇದ್ದಾರಾ?
Venkatachalapati. I think we can start.
Start ಮಾಡಿ.
ಸಂಜನಾ, ಜಾನ್ ರೆಕಾರ್ಡ್
ಜಾನ್ ರೆಕಾರ್ಡ್ ಸ್ಟಾರ್ಟ್ ಮಾಡ್ತಿದ್ದೀರಾ?
ಸ್ಟಾರ್ಟ್ ಮಾಡಿದ್ದಾರೆ ಮ್ಯಾಮ್, ಆಲ್ರೆಡಿ ಸ್ಟಾರ್ಟೆಡ್.
Already started recording.
Started
Then we
recording.
can start.
Good evening, President Venkatachalapati.
Yeah, good evening, sir. Namaste.
Anuradha, good evening.
Good evening, Dr. ಸುರೇಂದ್ರ ಅವರು.
ಮ್ಯಾಮ್ ಸ್ಟಾರ್ಟ್ ಮಾಡ್ಲಿ?
ಎಸ್ ಮ್ಯಾಮ್.
ಮಾಡಿ. ಮೇಲ್ ಕಳಿಸ್ಲಾ? ಮೇಲ್.
Ma'am, I request everyone to mute themselves. Okay. Shubha Sanjay ellarigu. Good evening, everyone. A warm welcome to all of you. Today, we from Imaksb WDW have organized a most important web talk on organ donation. August 13 is observed as a World Organ Donation Day. World Organ Donation Day. And it aims at spreading awareness and importance of organ donation. So the main objective and motto of this is to make a pledge to donate the organs after death. So which is the best way to provide new life for many. So keeping in this mind, our Anuradha madam has taken a step to arrange an organ donation talk in this month of August, as it correlates with or it corresponds to the organ donation month also. Like as we all know, 13th August is observed as an World Organ Donation Day. So we bring two eminent speakers, that is Sonal sir and Rekha ma'am. One will be speaking on organ donation and Rekha ma'am will be speaking on eye donation. So if I am not wrong, 1954 was the first, Sonal sir should correct me, 1954 was the first year where the organ donation took place. Correct, sir?
Yes, kidney transplant
By
happened
Dr.
first year.
Joseph Murray, sir.
That's correct.
Like they were identical twins, I think, sir.
That's correct.
Yes.
So in India, I think Vellore was the first institute to do organ donation.
Absolutely.
So let me give the platform to my chairperson, Dr. Savita Ramesh, ma'am, who is a chairperson of IMA WDW Women's Wing Subcommittee. She will give an introduction and also an introduction to the chairperson, Dr. Geeta Duppa. A welcome and an introduction to Geeta.
Good evening, one and all. I welcome Dr. Venkatachalapati sir, our president of Karnataka State Branch. I welcome Dr. Rajeshwari Amma ma'am, vice president of South Zone Karnataka Women Doctors Wing. I welcome Dr. Surendra sir. I welcome each and Sonal Asthana sir. I welcome Rekha Gnanchand ma'am. I welcome Dr. Sanjana Tallur, Dr. Anuradha Paramesh ma'am, and Soumya Sharan, and all the delegates of our Women Doctors Wing, as well as the persons who are attending this webinar, which is very informative, and we are going to learn so much of information regarding organ donation as well as eye donation. I would like to introduce Dr. Geeta Duppa, who's conducting today's, taking us the program.
Sorry to interfere. I am a prayer.
Yeah. I am a prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Jai IMA. Once again, I would like to introduce Dr. Geeta Duppa, who's conducting today's program as a chairperson. Dr. Geeta Doppa has completed her MBBS in Dr. VM Medical College, Solapur in 1997, and she's done her MD Obstetrics and Gynecology in Government Medical College, Meerut in 2002. She was the university topper of MD Medicine, MD OBG exams, awarded the Shantabai Kirloskar Scholarship. She is working in KVG Medical College and Hospital, Sulia since 2004. Presently, she is professor and HOD of Department OBG in KVG Medical College, Sulia, Dakshina Kannada. She's got Best Research Paper Award in OBG Karnataka State Conference, Kasoga at Manipal. She was Vice President of IMA Karnataka State Branch 2018 and 17 and 18. And she's President of Sulia IMA 2018-19. She has presented several scientific papers in national and international conferences and authored chapters in OBG textbooks. She's an undergraduate and postgraduate examiner and guided several MS OBG students. She was awarded the Kannada Kasturi Award this year in February. And she's been presently the member of Central Working Committee of Imaksb, member of Women Doctors Wing, as well as Academic Subcommittee IMA Karnataka State Branch. Over to you, Geeta ma'am, for conducting today's webinar.
Yeah.
Thank you.
Good evening.
Thank you, one and all.
Yeah. Thank you, Dr. Savita, for the introduction. So good evening, President IMAKSB, Dr. Venkata Chalapati, sir. Then Women Doctors Wing National Office Bearer, Dr. Rajeshwari Amma, who is our South Zone Chairperson. All the senior office bearers of IMAKSB. Then Dr. Savita Ramesh, Chairperson of IMA WDW, Dr. Sanjana, Vice Chairperson, Dr. Anuradha ma'am, and all the members of IMA WDW. So today we have a very important topic. Good evening, Yashoda ma'am. Yeah.
Good evening,
Welcome.
Dr. Yashoda ma'am. I would welcome you, heartily welcome you to our today's webinar.
Thank you, Dr. Savita.
Yeah. Welcome, Dr. Savita, Yashoda ma'am, for joining our webinar. Yeah. And so today we are having a very important topic to be discussed. Like 2 talks we have by eminent speakers. One is on organ donation and one is on eye donation. So the first talk will be on organ donation. So we all know this organ donation is really very important because it is said that without organ donor, there is no story, no hope, no transplant. But when there is an organ donor, life springs from death, sorrow turns into hope, and a terrible loss becomes a gift. So it's very important. So it is said that one organ and tissue donor has potential to save and enhance the lives of around 50 people. So it is not only the donor, the recipients who are being benefited, but the family and their friends are also so much benefited by getting the life back of their near and dear one. So we should all be aware about the organ donation, about the eye donation, and definitely we all should create an awareness about this very important organ and eye donations. So as Dr. Sanjana said, 13th August every year, we celebrate World Organ Donation Day to create an awareness about the importance of organ donation and encourage the people to take a pledge for the same. So today, let us move on to the first talk without any delay. So the first talk is on organ donation by Dr. Sonal Asthana. So Dr. Sonal is a lead consultant, hepatobiliary and transplant surgeon in Aster Group of Hospitals, Bengaluru. Dr. Sonal has done MS, MRCS, FASTS, MSc. He is adjunct professor, Biomaterial Engineering, Indian Institute of Science, Bengaluru. He has published more than 105 papers and various abstracts. He is also honorary consultant in Bangalore Medical College and Research Center in Bangalore. He is also the committee member of Jeevana Sarthakate, that is the Organ Allocation Authority of Karnataka. He is the member of Apex Technical Committee, the National Organ Tissue and Transplant Organization, Government of Karnataka. He is the course director of National Organ Donation Workshop 2014 to 2020. Dr. Sonal is a convener and architect of Indian Liver Transplant Registry. He is the founder executive member of Liver Transplant Society of India. So over to you, Dr. Sonal. So we want to hear from you regarding your talk on organ donation.
Thank you so much for your very kind introduction, madam, and thank you to the entire executive committee of the IMA Women's Wing for this invitation. I see Dr. Venkatachalapati, who I know well, and Dr. Anuradha also, who's reached out to me for this. So as you know, this is a very contentious topic, and I would like to give you over the next 20 minutes, perhaps all the pros of donation, as well as some of the challenges that we have faced in our journey as we have looked to develop organ donation in our country, in our state over the last 11 odd years. So I'll just share my slides if that's, please do let me know if it's, are my slides visible?
Yeah, they're visible. You need, perfect.
Perfect. So the topic today that I've chosen is diseased organ donation in India, that is 2 steps forward and 1 step back. And this perhaps feels like this every day. I was hearing about some of the discussions about Kalburgi, and in fact, there is a donation happening there tonight. So we can see that a lot of different parts of our state are coming into the map. So what does one think about when we think about organ donation? I think for most of us in India, this is probably the most evocative message. We think about organ transplantation from the times of our mythology, when Ganesh got a head from an elephant because his father cut off his head in anger. And organ donation, that's why the wisdom of the elephant perhaps was transferred on to one of our gods and has benefited us immensely and continues to benefit us today. In the longer term, we know that several of these the facilitatory effects of different organs have been described in mythology as well. This was the story of Prometheus, a Greek god who stole fire from the heavens, and his punishment was that an eagle would eat a part of his liver every day, and every night the liver would grow back. So this is again a commitment to our perhaps understanding of the regeneration of different parts of the body, which our ancients had. But what about transmission of organs, part A to part B? This again comes from European literature, where we have the 2 patron saints of medicine, Cosmos and Damien, who have transmitted or transplanted the leg of a Moor, the leg of a soldier, a black soldier, onto another person whose leg had to be amputated. You can see the difference in color between the legs. So these are all stories which may be apocryphal, but they actually convey the deep importance and reverence that even our ancestors or ancients felt about our organs, replacing parts that were defective or giving benefits that perhaps did not exist. So there's probably no doubt that India needs organ donation, because we are, apart from being, the chronic disease capital of the world, we are also the end organ disease capital of the world. So approximately 500,000 Indians die of end organ failure every year. Most of these people die of renal failure. In fact, 90% of the people who have developed renal failure in our country do not even reach or get benefit from dialysis. So there is a very, very big gap between demand and supply here, as you can see from this slide, where the renal failure rates are 226 per million population, but the renal transplant rates are just about 3 per million population. In liver transplant, the difference is also quite stark. The numbers of Indians who require liver transplant are probably around 20,000 to 50,000. The estimates are very wide. Approximately 1,500 transplants happen every year, out of which a very, very small number actually come from diseased organ donations. So where do organs actually come from? Most of our patients who come to me ask me in my clinic, "Illi organ sigata?" I mean, they actually ask in a fairly innocent way, and they generally have no idea, and they perhaps think that we have some sort of container like this in the back which has different organs which we can give them. I wish this was the case, because that would make transplant surgeons' life much easier. But the reality is that organ transplants are much, much more complex. So what are the other things that India has which are perhaps negative, but which can actually work in our favor? In India, we realize that we are also the road accident capital of the world. We have almost 12.5 lakh road traffic deaths occurring every year. This is the leading cause of death in younger adults, and out of 3 out of 4 people who actually pass away this way are men. But the reality again is that out of an estimated 35,000 people who potentially die of brain death every year, the donation rates are less than 1,000. So we are utilizing much less, of the potential organs that could actually benefit so many millions of people than we have access to at this time. So one of the eminent speakers before discussed the milestones in transplantation, and as she very correctly said, organ donation, the first successful kidney transplantation in the world, happened in 1954 by Dr. Joseph Murray in Boston, where he transplanted a kidney between identical twins. And in India, very interestingly, the first attempted kidney transplant happened by Professor Mukherjee in 1965. So India was not very far behind when it came to the West at the time when it came to developing organ transplant technology. The first successful organ transplant that came from a living donor in India happened in 1971 in CMC Vellore. And this year, in fact, we have completed 50 years of organ donation, organ transplantation in our country. It wasn't until 1994 when the Organ Transplantation Act was passed in our country that cadaveric transplant could be attempted. Although this was attempted very shortly after the law was passed in 1994, it was not only till 2001 that we had successful organ donation or transplants happening in India. And after that, the story has actually been one of steady progress, and we have not looked back. Transplantation, of course, needs organ donors. That goes without saying. We cannot transplant without either people donating after death or family members coming forward and donating in cases of paired organs or partial organs, such as the liver. Now, why does one have to project deceased organ donation? As you know, that we are doing a lot of living donors very safely and very successfully. The reason for that is that living donation perpetuates inequity in many forms, and this was actually what India was known for. India was known as the commercial organ transplant capital of the world. These are all poor laborers who had to give their kidneys or sell their kidneys at times, and this scam has actually been wiped out, but depressingly continues to recur in different forms, because as long as there is inequality, there will be people who are willing to sell their organs and people willing to buy them. The other important thing perhaps in this forum that is important to realize is that there is not just economic inequity, but there is also gender inequity in organ donation. Overwhelmingly across the world, most of the living donors are actually women. More than 60 to 70% of the living donations are done by women. This is actually a picture of all the living donations that have occurred in PGI Chandigarh over a 15-year period. And as you can see, although the technology has changed, but the people who are donating have not. Most of the donations still occur, living donations occur from women. So if we have to correct inequity in terms of economics or in terms of gender, then deceased donors is definitely a worthy cause to pursue. That perhaps brings us to the next step. What is brain death? Brain death was first defined in 1968 by a Harvard special committee, which actually realized that there is, because of advances in our ICU care now, there are two forms of death that are recognized. One is the death that we all recognize because the heart stops and the circulation stops, as a result of which all the organs lose their function. And this is cardiac death, and everybody learns about it. And as an intern, often our first or second job is to certify people who have died on wards, etc. Death to circulatory arrest. The second form of death is brain death, where all the functions of the brain are irretrievably lost. But because of machine support, the heart continues to beat and the organs continue to be perfused with blood. So in this situation, in this specific situation, it is possible to retrieve the organs and use them for other people who are in need. So this is the criteria that was defined first in 1968 and defined across the world. And this is basically one of the common indications where we come across that. When we see a normal brain right here in the center, sulci and gyri are very well defined. The ventricles are very well defined. And when you see a massive bleed that has occurred here, you can see that there is a shift of the midline, there's intraventricular bleed, and the parenchyma is completely squished, or diffuse axonal injury, which occurs after this, a brain injury, as you can see in these different pictures. These are the most common situations in which we encounter brain death. And again, the other part that we can diagnose this by is by EEG, where we know that normal brain waves completely disappear, which shows irreversible loss of brain function in patients who have had brain death. So India's story started in 1994 because it was a very unusual story. The law itself has several twists and turns. This was first passed by the Indian government, the Union Indian government, on the request of certain states in order to define brain death. And this law was the Transplantation of Human Organs Act, or called the THOA, which was passed. And according to this, each state was given the power to pass an appropriate authority and form authorization committees. So this was an important or a pivotal law. It defined brain death. It set the criteria for testing for brain death. It defined the legal process that had to be followed before brain death and declared and organs could be offered out for organ donation. It set out the entire regulatory framework for donation, as well as laid out commercial penalties for commercial organ trafficking. So this was actually a very big landmark bill. It was expanded in several iterations in 2009, 11, and 14, and now it has become the Transplantation of Organs and Tissues Act. Again, as one of the chair people was saying earlier on, it's not just organs that are important, but tissues are also important. This was also covered by this particular law in 2011. Now, brain death, as we have discussed, is the irreversible and the permanent loss of all brain function. And a deceased person is a person in which brain death has occurred. So this has also been defined. So now we have two forms of death. We have cardiac death and we have brain death. And once brain death has happened, once we have lost all functions of the brain, this basically means that the GCS is 3/15. They are unresponsive to stimuli, and the cessation of all stimuli, brainstem reflexes. Then a person can be declared dead. The process for this is very well defined in our law. The tests have to be defined by reflex tests and apnea test, which is the coronary testing. These tests have to be carried out by 4 independent physicians in 2 sets of certification, 6 hours apart. These physicians have to be completely independent of the transplant group so that there is no bias in testing. So I cannot stress this enough, that we do not get involved in organ allocation until it has been signed off by a committee that has got nothing to do with transplantation. This is to maintain objectivity and the sanctity of the process of brainstem testing. After this, the entire process of organ donation, organ allocation testing comes into place. And there are multiple stakeholders. The JSK in the middle is the Jivas Arthakate, which is the organ allocation body for Karnataka. And there are different bodies in different states. So as you can see that there are multiple stakeholders, the ICU team, the transplant team, the family, the government, social workers, religious leaders. This is always a media event. So you must always be mindful of that, as well as the police in cases of medical legal cases. So what does the Jivas Arthakate do in Karnataka? It maintains a donor registry. It maintains a recipient registry. It provides 24/7 coordination of all organ donation activity in the state. There are medical coordinators who advise on all potential donor screenings and medical aspects, and transplant coordinators, they supervise the allocation of organs in between hospitals. So there are several bodies in India that are working very actively. Some of them are NGOs. The Mohan Foundation has completed 22 years of existence in India right now. This is one of the oldest organizations that is involved with organ donation, but there are several other organizations that are also doing a very, very good job of promoting organ donation in their particular things. And the other thing is, of course, the committees. Jivas Arthakate, one of our committees here, is one of the oldest committees in India, which has got a very long and distinguished history. Of course, there is a cadaver transplant program in Chennai, which is run by a body which is currently directly reporting to the NATO. There is the ZTCC in Mumbai, the Orbo in Delhi, and the KNOS in Kerala. So what are the challenges on organ donation? Firstly, so far, organ donation has been led predominantly by champions, individuals who are very passionate about the cause, and they have not been supported by either a legal system or an administrative system. In fact, several of the initial champions were actually vilified, and they had legal cases put against them because organ donation was not recognized and was viewed by suspicion. Organ donation, donor management is poor, donor costs are still not very covered, and programs are infrequent. And of course, most of the people who manage the regulatory agencies do not have domain knowledge and do not know the law very well. So of course, the governmental challenges are that we have to prevent biases on organ allocation. The organ allocation process has to be transparent. The process has to be very clear. Everybody should understand that. And how public sector works with private sector, those are things that need to be defined. as well as how national bodies work with state bodies, because as you know, health is a state subject rather than a national subject. So the implementation of this law differs from state to state. So clearly there have to be very good SOPs that define how all these bodies should work and talk to each other. So what can we do? The perception problem. Now the entire committee, in fact, I'm sorry to say that the public feel that this is what organ donation is all about. Only rich people can benefit, and there is always going to be some hanky-panky in organ donation. So we have to have fair and equitable access. The process of cycle of control is completely controlled by the government. It has to be seen to be fair. It has to be seen to be transparent. The steps forward that we have done over the last 10 years are improvements on organ donation rates, improvements in technology, as well as improvements in access, which is something that I'm very proud of, and I will talk to you about as well. The one thing that we must realize is that organ donation is increasing in our country. Even since we started working in Karnataka, I came here in 2010-11. That year, there were a total of 9 donations in the entire state. The year before COVID, 2019, we had a total of 111 donations in Karnataka. So you can see that the organ donation rates have increased almost 12 times in just about 10 decades. And even across the whole country, we have seen only the states that are marked in orange here have yet to start their account on organ donation. All the other states actually have registered some organ donation now. Organ donation rates have increased. Of course, organ donations are occurring in smaller cities, so there are logistical challenges. So now we are seeing a lot of donations happening in North Karnataka, which is great. Donations are happening in Hubli, donations are happening in Belgaum, in Kalburgi, which is just a testimony to the awareness among our public. And now we have to figure out the logistical challenges of transport and making sure these organs are utilized. Of course, the organs that are coming to us are also now from older donors, slightly more poorly managed. You can see that this donor has a very fatty liver. So these are the challenges that we need to see, that the quality of the organs that we are getting is a little bit less as compared to early on, because as the criteria and the indications increase, we are getting donors of all ages and sexes, etc. Organ donation rates have increased in this thing. These are the rates across the country over the last 4 years. And in fact, now, contrary to public perception, it is not Tamil Nadu, but actually Maharashtra that has been leading the way for the last 3 years when it came to the number of organs that have been donated. Of course, Tamil Nadu set the tone. Over the last 2 decades, Tamil Nadu established several excellent processes that have been copied across the country. But now, Tamil Nadu, Telangana, and Maharashtra are actually doing very well in organ donation, and Karnataka stands fourth. And most of the organ donations today occur in the south and the west of the country. But this dwarfs the number of organs that are required. As we have discussed before, the number of renal transplants that occur are probably less than 3% of what is required. Less than 5% of people who require a liver transplant get it. And the numbers are very dismal for heart and kidney, for pancreas, etc. And in fact, India now has a dubious distinction of being one of the third largest organ transplant provider in the world, but with a very, very small deceased organ donation program. This is also borne out in the Indian liver transplant registry, where 20% of the organ donations, organs transplanted, come from deceased donors. But when you look at it, most of these deceased donors are occurring in the south or the west of the country as opposed to the north. So there is a very big geographical divide even within India itself. So what are the technological advances that allow us to do organ donation? One is splitting organs. In the liver, for example, now we can use one part of the liver, which has the right and the left lobe. We can split it to give it to one adult and one child. So with one organ donation, we can actually benefit 2 people. And there is something called a domino transplant, where actually in certain genetic indications, we can take out the liver, which is morphologically normal. This is familial amyloidosis, for example, that is one indication. And that liver can be transplanted to someone who has cirrhosis. And then by one donation, we can actually benefit 3 people. So these are some of the indications by which we are able to utilize one organ in more than one patient. And this has been done successfully in Bangalore. The other things that we have done include, transplanting very, very small children, doing bloodless liver transplant, which is something that the number of donation on the blood, as well as using what is called 3D printed assisted transplantation, where we are able to plan out all the operations very well. So this, as you correctly have mentioned, because technique-wise, we are probably second to none in the world. We are able to do whatever is done anywhere across the world. So definitely, when it comes to our medical fraternity, we have stepped up and we are trying to make the best of whatever organs are offered out and give our patients the best care possible. Another very important step forward, in my view, is machine perfusion, which is basically nothing but an oxygenated machine which can circulate blood in an organ which is kept outside the body, and then it can maintain the organ in almost like a normal situation for several hours. This is actually a revolution in terms of organ transplant, transplant and transport. So you can imagine that if an organ is donated, say in Kalburgi, then the organ can be put on the machine and the organ will behave like it is actually present in the body, and it can have blood circulation, it can have nutrition until it is brought back to a place where organ transplant can occur. So this has facilitated not just the rehabilitation of organs, but also the transport of organs. And this is again something that we have done in our practice here. Now, what is the one step back? What are the negatives of this? Right now, equity, as we mentioned, there is still a perception that organs are not being allocated fairly. They're being allocated only to rich people. There is a lack of public trust and participation. And this also impacts organ donation, as I will tell you, and of course, access to transplantation. This is actually brought out very, very aggressively in our media, because as you know that the media does add to and report on the perception that right now organs only get to go to the rich. And of course, there is always that doubt about organs being allocated to foreign nationals, which have created a lot of distrust in this donation system. And this has impacted organ donation rates in certain states. In Kerala, for example, there was a lot of adverse media publicity over 2016-17, and this impacted organ donation rates significantly. Because please remember that trust in a community or organ donation is built up by many stakeholders, including the media. So it's important for us to be responsible, but it's also important for our colleagues to be responsible when it comes to communicating news, because once trust is lost, then it is very, very hard to recover, and it directly impacts organ donation rates. So what can we do to improve our organ donation rates? One is improving awareness, as we know that compared to 10 years ago, a lot more people are aware about organ donation. Even our patients currently, if you talk to them about brain death, they are aware about organ donation. Many of our, in Bangalore especially, many families actually come forward voluntarily when we talk to them about brain death. The doctor, can we donate our organs? Now, of course, we have to implement our law better. The law has been designed very well, but people have to be familiar with the law, and SOPs have to be very standard, transparent, and easily applied. This is something that is work in progress. And I must say that I'm very proud of the progress that Karnataka has made, in terms of standardized training, declaration, etc., and counseling, etc. We are using organs that were previously perhaps unusable because of technology advances, and this is machine perfusion. And the last bit is the most important bit. We have to make transplant accessible to the mass. So over the next few minutes, I'm going to tell you about a novel program that we have started in our setup, which is probably the most novel in the world, which has made us one of the leading pediatric liver transplant program in the country. So transplant accessible, we actually have developed something called the Karnataka model, where we developed a program in partnership with the government sector in Bangalore Medical College. You may have heard in my introduction that I am adjunct faculty at the Bangalore Medical College. This was for this reason, where along with Dr. Nagesh at the PMSSY in Bangalore Medical College, we developed perhaps one of the few programs in the public sector where transplants were being performed for people who could not afford private sector rates. The other important thing is making transplant affordable. Now, I would like to tell you about a way in which we can make a 25 lakh transplant. We can do it for 2.5 lakhs. Now, most of you might feel that this is impossible to do, right? But I will explain to you exactly how we have done this here. We started something called the Affordable Transplant Initiative, which is focused on children, so that children with liver failure should have access to liver transplant regardless of their family's economic status. So as you know, the cost of transplant in India is actually not high compared to the world. In India, transplants cost approximately 90% less than they would cost in other countries. But actually the problem is in our patients' capacity to pay. Most of our people have to sell their property, sell their jewelry, take loans in order to afford the cost of 15, 20 or 25 lakhs, which is a huge amount. And it's important that we do not put our patients in this catastrophic out-of-pocket expenditure. There's massive debt that we can do. So we use something called social.
I ate quite a few and covered and kept.
Unmute ಮಾಡಿ please.
Spoil
Right. So social media was actually what we turned to. As we know, social media has a lot of positive and negative connotations in today's world. But generally speaking, we decided to use the power of social media in order to help our patients. And we know that if Facebook was a country, then it would probably be the third most popular country in the world. And India has the largest number of Facebook users in the world, almost 300 million or 30 crore people are on Facebook in India.
Evening ಮಾಡ್ಬಿಡಮು evening 7 o'clock ಇಂದ 10 o'clock 6 o'clock ಇಂದ 10 o'clock ವರೆಗೂ ಮಾಡಮು.
Okay, so just so that we understand, if we do a thought experiment, if the total number of Indians on Facebook had to fund the entire Ayushman Bharat, only the people on Facebook, if they paid 210 rupees per year, then the entire health budget of India for Ayushman Bharat could be funded. So this is the power of Facebook. This is the power of social media in our country. Drops can make an ocean. So based on this, we created a mechanism by which we were able to reduce the cost that the family paid through only 2.5 lakhs. And we were able to raise the rest of the funding through crowdfunding, through corporate sponsorship and subsidized drugs, so that people could undergo a transplant in just about 2.5 lakhs. So this is basically one example. This child, Tanmay, had a hepatoblastoma. His father drives an Uber taxi in Bangalore. Father was the donor. He came forward to donate, and for this child, we were able to raise a total of 18 lakhs in just about 3 days alone. And we transplanted him about 5 years ago. So he's alive and well 5 years after his transplant. So basically, what we have realized is when we do these crowdfunding appeals, we have several donors, almost 1,000, 1,500 plus donors per campaign. The average size of the donation is only 2,000 rupees, but many, many drops make an ocean. So as you can see, many drops of these 2,000 rupees can add up to very, very large amounts. And over the last 5 years, we have raised a total of almost 12 crores to support 102 pediatric transplants that have been performed in our center. So we are one of the largest centers in the country that performs pediatric transplants by this. And we are very proud that this unique mechanism of funding healthcare is now a case study at IIM Ahmedabad, which is now taught across management schools as a mechanism of funding children or funding healthcare costs through philanthropy. These are some of the children who have benefited from this mechanism. Tanmay, who we just talked about, this is his father, who's still driving a taxi here, and that's his mother. Tanmay is doing very well. Another child, Lakina, who's here, who's a budding artist. So basically, I'd like to summarize and stop here that we've made a lot of progress over organ donation in the last decade or so, and we are definitely better than we were 10 years ago. Now, there are several negative points that have also occurred, mainly because of a lack of public trust and lack of engagement. It is also up to us, it is our responsibility to address some of the points why people do not trust us. One of the points is by making transplant accessible to even those who are not able to afford it. And I think that is probably the key message that I would like to leave you with. Thank you so much for your attention.
Thank you, Dr. Sonal, for the excellent presentation. So you have really very nicely explained about the deceased organ donation. And we have understood from the talk that there is a large gap between the demand and the supply of the organs. Because as you said, around 20,000 to 50,000 livers are required, but actually only 1,500 transplants take place. Also, RTAs, around 35,000 RTAs take place, and only 1,000 organ donations we get. So really, it's been 50 years since we have started organ transplantation, but still I think we have a long way to go. But with dedicated surgeons like you, definitely India will be still more progressing in the years to come. And what we understood is, in India, what are the reasons why we are lacking is mainly lack of infrastructure, then logistical constraints, then few myths and stigmas which are associated with the organ donation. So definitely, as you said, it's our duty to tell to the public, create awareness about the importance of organ donation. So shall we take the questions in the end? Are you there till end, sir?
Yes, please, madam.
We'll take the questions in the end. So now let's move to the second speaker. So our next talk is on eye donation. So definitely we know eye donation is so important. And the next speaker for today is Dr. Rekha Gyanchand. So I would like to introduce Dr. Rekha ma'am to y'all. Dr. Rekha Gyanchand has done her MBBS, DOMS and MS. She was the best outgoing student in MBBS and has received a gold medal for that. Then she is a young surgeon, Rotary Award in 1997 at Bengaluru, Best Fellow, Lions Eye Hospital in 1993. Then Dr. Sita Lakshmi Cornea Award at Shankar Netralaya, Chennai in 2010. She has received training on anterior segment corneal disease and eye bank in Lions Hospital, Bengaluru, anterior segment and cornea in 1998 in Queen's Medical Center, Nottingham, UK, eye banking and cornea at Istanbul by IFETB Turkey in 2000. So ma'am is an anterior segment and cornea consultant, South Zone chairperson. She is also the member of Eye Bank Association of India. She is the medical director of Lions International Eye Bank, Bengaluru. She is a visiting consultant at Bengaluru West Lions Eye Hospital, BEL Hospital, and Mallige Hospital, Bengaluru. She runs her own Orchid Eye Clinic, and she has done various presentations in national and international conferences and has a number of publications to her credit. So over to you, Dr. Rekha Gyanchand, ma'am, for your talk on gifts of sight, facts on donate eyes, donate cornea.
Good evening, everybody. I would like to thank Dr. Anuradha and the IMA team for giving me this opportunity to be with you all today evening. After hearing the liver transplant and the organ transplant, I thought eye donation is much more simpler and easier. But yes, of course, we have our own problems are there. I'm sure all of you all have experienced darkness, and darkness is always scary. So darkness is equivalent to blindness. So now we can imagine how difficult it is for a blind person to continue his life. So if you look at the statistics of blindness in the world, 45 million are blind in this world. 90% are from developing countries. 1 person in the world goes blind every second, and 1 child goes blind every minute. Now, if you look at the Indian statistics, 15 million are blind. In that, 4.6 million are corneal blind. Every year, 25 to 30,000 patients are added onto this list. And the incidence of blindness is very high in children and adults, as that is the future of our country and our working population, and they get affected more with corneal blindness. Now, what is the present status of eye donation in India? There is a shortage of donor eyes. Awareness needs to be increased. COVID has created a great gap between donation and sight restoration. Pre-COVID, we used to collect about 50,000 eyes per year, but now it has dropped down to 11,000 eyes after in this COVID era since last year. So the eye donations have really dropped down very drastically, and this has affected our corneal blind patients. Now, if you classify blindness, you have blindness due to various causes. You have one group which is preventable, that is vitamin A and injury, you can prevent the blindness. The second group is there are certain blindness where there is no treatment, like retinitis pigmentosa and optic atrophy. But there is one set of blindness which is curable. In that, cataract is very simple because you can get operated in any of the hospitals. But the corneal blindness is something that is a social responsibility to give them sight. So why is eye donation given so much of importance? So that is given importance because only with eye donation can we treat a corneal blind. So this is the miracle of corneal donation and sight restoration. You see the first slide, that's the normal eye. The second is a corneal blind eye. There's an opacity on the cornea. The third figure shows post-transplant. So the post-transplant and the normal eye almost same. So the sight restoration is excellent. So there are various causes of blindness. You can have congenital or acquired. And all these causes, what happens, you get a scar on the cornea. And many of these, like, they come, like, vitamin A deficiency, I'm sure the physicians will be seeing them first. So that can be treated and prevented. The malnutrition is something, again, can be treated and prevented. And we always need to inform about taking care of our eyes, not to injure it, especially during our festival seasons like Diwali, and when we are working in the garden, not to accidentally injure our eye. These are the various, this photo I've put just to highlight and how the corneal blindness is. These are various diseases of the cornea where you get an opaque scar on the thing. So an eye donation can restore sight to these individuals. So now who can donate eyes? All can donate eyes, right from young to old, even if a person is wearing spectacles or contact lenses, even following an eye operation like cataract or LASIK correction. If the individual is a diabetic, hypertensive, or asthmatic, they can donate. Road traffic accident also cases also they can donate, and death due to poisons, consuming poisons, they also can donate eyes. Now, who cannot donate eyes? Now we have COVID on the list, that COVID positive cases, more than 20% burns, septicemia cases, rabies, encephalitis, hepatitis, HIV. And any of these infectious disease like TB, gonococci, syphilis, malaria, H1N1 or dengue, if they should be 12 months should have passed after their treatment, only then the eyes can be donated, or else no. The second group is the cancer group. Many cancers we have started using the eyes, except if the cancer is suspected to be due to a viral etiology, cancer has occurred in the eye. The primary cancers like leukemia, Hodgkin's, lymphoma, sarcomas, again contraindicated. If the cancer has metastasized to the head and neck, radiation given on the face just before death, or chemotherapy given 3 months prior to death. These are some of the contraindications in cancer. Contraindications for inner central nervous system disorders, it is Alzheimer's, multiple sclerosis, Parkinsonism, and active meningitis, encephalitis. These are some of the contraindications. We don't retrieve the eyes. When can eye donation be done? Eye donation is always after death. Brain death cases, we are the last one to collect eyes, but because as per law, it says eye donation is only after death. So once all the organs are collected, only then we collect the eyes. Now, what's the temperature? So if the cadaver is at room temperature, it is between 6 to 8 hours of death, we can collect eyes. But if the body is refrigerated within 6 hours of death, then we have 12 hours extended time for retrieval of the eyes. Now, pre-death donation is very important, that we need to close the eyes of the deceased. We need to switch off the fan and elevate the head, so that the head is at a higher level, and keep the death certificate ready. Now, once we get a confirmation that the eyes can be retrieved, and we confirm that the patient is dead, and also check the death certificate if it is ready. But many times we find the death certificate is not ready, as it may be in the middle of the night and things like that. So then we need to certify that death. Then age of the donor is noted, cause of death is noted, time of death is noted, medical history needs to be documented. If now we take the history of COVID history and vaccination history, any blood transfusion given in the last 24 hours, and any blood investigation reports if available, we have a look at it. Consent, very important, next of kin, 2 members need to give consent. The other important thing is the person who gives a consent has to be around when we are retrieving the cornea. If the consent form has been signed and the next of kin is not available on site, then also we do not collect the eyes. So in medical legal cases, we need, of course, the consent of next of kin and the hospital medical director or the superintendent's signature. Police consent and forensic chief consent is very important before retrieving the eyes. After taking the consent, in case of medical legal case, a gross physical examination is done to check for bruises, any abnormal tattoo mark or injections. And nowadays we do a rat test for all cases before retrieving the eyes. And we also draw 5 ml of blood for serology, that is HIV, HBsAg, HCV, and VDRL. These tests are done in the lab, but on spot a rat test is done. Now, procedure of eye retrieval. Normally, we collect only the corneoscleral button. So the whole globe is not removed. Full globe retrieval is done only if it needed. If we need the sclera or if we need the limbal area, then we retrieve the whole globe, or else we do not retrieve. The second thing, we do not retrieve the whole globe if the patient, if the donor was on blood thinners, then there will be profuse bleeding post enucleation. The whole eye retrieval procedure takes only about 15 to 20 minutes. There's no disfigurement of the face. We place an artificial eye and close the lids. So this is a picture to show that pre-retrieval, pre-donation and post-donation, it doesn't make a difference to the physical appearance of the face, as many people get worried and they don't want to donate eyes. So storage of donor eyes and cornea. If we collect the whole eyes, we store it in a moist chamber. If we collect only the corneoscleral button, we have various media. The most popular is the MK media. So here we have moist chamber method. We can store the eye for 24 hours. MK media for 5 days, and cortisol or optizol we can store for 14 days. Now there are various types, various eye banks in Bangalore. Like you have the government eye bank, that is the Minto eye bank. Now Lions International eye bank is an NGO eye bank. Then you have the private eye banks also. And so any of these eye banks can be contacted. I think I've sent the number and the pledge forms across in WhatsApp to Dr. Anuradha. So what's the function of an eye bank? These eye banks are registered government bodies. It's a non-profit organization. They collect eyes, evaluation of cornea, distribution of corneas to corneal surgeon, and they educate the community about the eye donation. Now, eye banking has become a profession by itself. It has a medical director, it has an eye bank manager, there's a chief eye bank technician, there's a tissue evaluator, there's an eye donation counselor, and we have an eye donation coordinator also. So I'm attached to the Lions International Eye Bank. This was started in 1984. This is the only accredited eye bank for the state which does the quality eye bank, and it is accredited by Eye Bank Association of India, and SightLife is an international organization which does the accreditation for selected eye banks in our country. And we distribute corneas to all the corneal surgeons in Bangalore, in Karnataka, and if necessary, even outside Karnataka. So on receiving a donor eye, what work goes on in an eye bank? The medical history and the transfusion history is checked. Serology is done. Slit lamp biomicroscopy examination is done. Specular microscopy is done. Here we count the endothelial cells of the cornea. And the final decision is whether we release it for transplantation and the type of transplantation, or if it's unfit for transplantation, we provide it for hospitals to teach surgery for the doctors. Or if it's a case of some interesting corneal finding we have come across, or there's some finding in the retina, then we send it for histopathology study. So the blood sample collected, we do an HIV, HCV, HBsAg, VDRL, and sometimes we also do the COVID antibody test. This is done especially when we receive eyes from our eye collection centers. The quality eye banking and quality maintenance is very important, and the way we retrieve and the way we process the eye, because you see a patient comes with a corneal blind. Suppose we don't evaluate the cornea properly, or due to some reason we have missed out some infection, instead of giving a clear cornea, then we again post-operatively the patient can have some problems in the cornea. So a proper evaluation by a trained person is very important. So especially a lot of children are waiting for transplantation, and because of the acute shortage of corneas, especially for the last 2 years. So there are some eye bank ethics. Eyes are never purchased or sold directly or indirectly. The recipient receiving the cornea will not know the donor family or who donated the eyes. Even if an individual has pledged his eyes and the family members do not give consent for retrieval after his death, we cannot collect the eyes. So it is very important when an individual pledges the eye, the family members must be convinced that their eyes will be donated after death. So what is this pledging? Pledging is a desire to donate eyes upon one's death. Whenever an individual pledges, inform your family members, inform your friends, inform your family doctors. That's very important. This is the pledge forms which is available, and this can be filled up and submitted. And now we also have a QR code for eye donation, which can be scanned from your smart mobile, and then automatically you're taken to the eye bank, and then you get registered as a donor. Now, what's special about corneal transplantation? Here, the whole eye is not planted, only the cornea is used, no substitute for human corneas. There's absolutely no substitute. There's a lot of research going on in this, and there are a lot of prosthetic corneas are being coming out in the research process. There are cases we do keratoprosthesis also we do when we find these some cases are unfit for corneal transplantation. Those corneas are made up of PMMA. So success rate is very good in corneal transplant, and it depends upon the primary diagnosis. Lifelong immune suppression is not required. Rejection can occur, but it can be easily treated. No disease transmission through the donor cornea, as it is avascular, and all the precautions are taken to see that there's no transmission of any disease. Now, always we talk about corneal transplantation, but now we use other parts of the eye also for transplantation. One is the limbal transplant. Limbal is the area between the cornea and the sclera. That junction, you have the limbal stem cell, or the storehouse where the cells multiply. Especially cases with chemical burn where the limbus gets burnt in the patient, then we transfer the limbal tissue into the patient. Scleroplasty is also another procedure where the sclera gets thinned out because of rheumatoid arthritis or trauma, or even glaucoma surgery. We use the sclera. And of course, cornea grafting is done with the cornea. Corneal transplantation has advanced. Earlier, we used to only do a full thickness transplant, but now depending on the disease, either we can change the anterior or the front portion of the cornea, or the back portion of the cornea can be changed. So this is how it is just exchanged, and then the patient gets back sight. The role of doctors in eye donation. Doctors are an important link between the eye bank and public. Patients trust only their family doctors, and medical history can be provided to the eye bank by the family doctor. You can always have a clinic of eye donation in your clinic or hospital, and you can also have pledge forms and facts of eye donation in your waiting room. At your CMEs, you can have a counter on eye donation. Whenever a screening camp is conducted, like maybe a blood donation camp or a diabetic screening camp, you can have a pledge counter there to create awareness about eye donation. Eye donation is very simple, and eye donation is only after death. There is no delay in funeral arrangement. Eye collection takes only between 15 to 20 minutes. Retrieval can be done at a residence, hospital, or mortuary. No disfigurement of face. Eye pledging is not a must for eye donation. Eye donation can be done if a person has cataract or poor vision or diabetes, hypertension or old age. We should remember that one pair of donor gives sight to two corneal blind individuals. So one donation, two people get sight. So I would like to say, let us all join hands together to restore sight. Thank you.
Geeta ma'am, unmute ಮಾಡಿ. Unmute ಮಾಡಿ.
Yeah, sorry. Excellent talk by Dr. Rekha ma'am. So now we have come to know that from the pre-COVID to the COVID era, the eye donations has drastically stopped, reduced, I mean, from 50,000 to around 11,000. So now we should see that they increase, and definitely for corneal blindness, this eye donation is very important. And so many of the myths really, which we also had, like we also used to feel that the patients who have undergone cataract surgery or LASIK especially, they are not suitable candidates to donate the eyes. But as Dr. Rekha ma'am has said, they can also donate the eyes to the needy. Definitely, madam has told us who can donate and who can not donate the eyes. And it's such a simple procedure of about 15 to 20 minutes, which can give vision to two needy people who are in need of the eyesight due to corneal blindness. So if any doubts are there, kindly put in the chat box. Both our speakers are there, so we will take the doubts.
Rekha ma'am, can you add few words about, what a common man or anybody can do till the eye is donated, like closing the eyelids or keeping a wet cotton over the, any few things if you suggest, I think will be helpful.
No, actually, you shouldn't keep any cotton or anything. You just close the eye, and if there's a fan over the head, you off the fan. And the pillow, what we say to give two pillow to elevate the head, and that is only if enucleation is being done. If you're doing only a corneal excision, even that is not required. Just closing the eye.
Closing the eyelids should be important.
Yeah, that's all. No need of keeping a wet cotton. Nothing is required.
Okay.
That was the instruction giving long back. Now we have stopped that. Because we found that it is I used to get sort of, infection was more with that.
Okay.
Because they put it in water and they keep it over the eye, so it gets contaminated. So we stopped saying that.
Thank you.
Yeah. One question to Dr. Sonal. Now, when we are doing Dr. Sonal is there?
Yes, ma'am. I'm here.
So, sir, now after the organ donation, like it may be the kidneys or the livers, like how long that will be beneficial to the recipient? Is it lifelong or it has some year span, like 8 years, 10 years?
So, that's a very good question. Each organ is a little bit different in terms of the immune acceptance in the body. So, for example, corneas are actually especially blessed because, they're actually quite far away from the immune system. So, although they do need anti-rejection medicines as well. So, generally speaking, kidneys can last for anywhere between 10 to 15 years. Heart transplants, again, for a similar period of time. Lungs are a little bit less right now, between 4 to 5 years, in some cases 7 to 8 years. Pancreas for approximately 10 years. Livers are probably very immunologically privileged because livers can last for the entire lifetime of an individual. So like the longest liver survivor is about 47 years after their liver transplant, the first transplant done in 1970s. But that being said, it is different for each individual. These are all average numbers. There are people who are alive after 30, 35 years after kidney transplant and after 25, 30 years after their heart transplants as well. So certainly I think that given the progress in terms of anti-rejection medicines, that is not a limiting factor in terms of survival. Actually, access to an organ is more important.
Yes, sir. Thank you, sir.
Sir, one more question, sir. What about doing in a immunocompromised patients, sir? Organ donation in an immunocompromised patient like HIV?
So typically, the indications for organ donation are progressing every, on a regular basis. Before it used to be that hepatitis B, hepatitis C, and HIV, the seropositivity was considered to be a complete contraindication to organ donation. But now, as you know, that there are very good drugs available for hepatitis B, C, and HIV. So there are certain conditions in which we are taking on organs in order to match them with the recipient. For example, taking an organ from, say, an HIV positive patient who does not have AIDS and giving it to another HIV positive recipient does not have a negative connotation. Same way, taking an organ from a hepatitis C positive patient and giving it to somebody for whom you can give antiviral therapy after the transplant may not have a lot of negative connotations for them. So there are a lot of moving targets for this. So what I would request all of you is that if there is a patient who fulfills criteria, please do ask, because these are such dynamic targets that sometimes that people who we sometimes assume are not candidates for organ donation actually might end up benefiting somebody. So please do reach out and ask the Jiva Sarthakate or the local bodies because these deadlines are actually evolving very rapidly.
Okay.
Thank you, sir.
Dr. Rekha, madam, are you related to Dr. Gyanchand, madam?
Yeah, my father, sir.
He was radiologist in Victoria Hospital, no?
Orthopedic surgeon, sir.
Orthopedics, yeah, Gyanchand is orthopedics. Oh, you're daughter of Dr. Gyanchand.
Yes.
Okay, I met him, madam. I met him. Thank you.
Any other doubts for the speakers? Anyone has any doubts? Kindly put in the chat box or you all can directly ask.
Dr. Rekha, I have got a question on WhatsApp. One sec, I'm going to read it. Dr. Vimochana, pediatrician, is asking this question. Can you please ask about pledging registration for eye donation? Should registration for eye donation be online only? If it had been pledged earlier, old cards from Minto, are they valid?
Yeah. See, once you have registered, it is only for your awareness. That is, it is not required that, you again need to register in another eye bank because you're already registered. Again, you register in some other eye bank, it gives a false number that so many people have registered. Because every month we send our statistics of number of donors, people who have donated eyes and number of people who have pledged their eyes to the government. So they have a record. So it will be a reduplication and it's not required again to re-register. Once you have registered, that's sufficient.
So I request Dr. Sonal to guide us doctors, your professional colleagues, about how we need to, how much we, of course, we all know tidbits.
Like, how can we help you?
Exactly. No, I think, certainly, madam. I think that firstly, obviously, awareness among our colleagues, among the doctor fraternity is very important about brain death. And secondly, what we have realized is that many people are hesitant to talk about brain death to our patients, actually. And I must thank our, our ophthalmology colleagues for this, because of their efforts, eye donation has become acceptable in the fraternity over the last few decades. So often that is a very good starting point for us to talk about organ donation. When we say that, are you willing to donate eyes? And then we can, if people are willing, then we can actually take the discussion further about other organs and such. So I think that starting that discussion is very important. Equally, your patients, if some of them may come back to you, if somebody is admitted, loved one is admitted in ICU and they've been told about brain death. So they might ask you for their opinion, because again, Dr. Rekha has emphasizes the role of the family doctor is so critical here, because they are the people who, you are the people who they trust actually. So they will come and ask you, that they have told us about brain death in the ICU. So what should we do on that? Those are the times when, some positive encouragement, some words of advice would be very helpful. And equally, we've realized that most of our colleagues, are also faced in that situation where they are reluctant to test for brain death, because nowadays people are worried about their patient personal safety. Patients are abusive sometimes, patients are violent sometimes. So people always worry about their personal safety. So I think that breaking bad news, that communication, if it is taught in medical schools, taught in IMAs, taken up as a project, then that will actually make a very big difference in the way that we are able to communicate this effectively to our patients.
Like we have read on 2019, there were many number of transplantation. Like next to USA, India was the largest country for organ transplant. But at the same time, the donation was very less. Organ donation was very less. So how can we bring awareness of these things in a normal patient? Like you talked about eye donation, the same way I'm asking about organ donations.
Yes, ma'am. So I think the first thing is to start a conversation. Start a conversation among our physician colleagues. Start a conversation with our patients. Make sure that patients, when they reach out to you for advice, are getting appropriate advice. Okay. And more importantly, we have to address the question of inequity, because a lot of people still believe that transplantation is only for the very rich. No. So, like,
Yes,
for example,
that is like it's a myth, like it is for only rich.
Yeah.
One who can afford for it, they can undergo for a transplant.
Absolutely correct. So I think that now transplant programs are available in the public sector. And in fact, as I've shown you one example for pediatric transplant in our center, we are able to do transplant for only about 2.5 lakhs to a family. So patients come to us from all across India now to avail of this facility. So I think that every patient who benefits like this from a affordable transplant is an ambassador for you, because they now see transplant in a positive light. That means I can benefit from transplant. So why not I help somebody else? So because transplant is a community effort, it is not just about us sitting in one hospital doing a transplant. It has to be, patients have to be aware, family doctors have to be aware, the community has to be aware, and they have to be supportive. Otherwise, organ donation rates will actually fall. So I think that starting the dialogue in the doctor community, starting a dialogue with your patients, giving good advice when advice is asked for. And of course, most importantly, pointing out that if someone needs a transplant, there are mechanisms to help them to get a transplant. So those are probably the key points that I would say are very critical for this audience.
Dr. Sonal?
So now we have a question in the chat box here for Dr. Rekha. How early after death you can have to retrieve the eye? And if eye is retrieved late, then does it last long after transplantation?
No, actually retrieval has to be done within 8 hours of death. If the cadaver is stored at room temperature, but if it's refrigerated within 6 hours of death, then up to 12 hours retrieval can be done. Basically, once the time crosses, we do not collect the eyes. The reason for it is there's a lot of because of the cell death, we find pseudomonas growing very rapidly in them and post-operative infection. So once the time factor is crossed, we do not retrieve the eyes. And it has, so once within 8 hours we retrieve, then it has no relation with the duration post-transplant results. There's no relation between that.
Thank you, ma'am.
Dr. Sonal, what I feel is we need to bring awareness amongst our professional colleagues. No point talking to the patient about brain death. In fact, they will run away from their doctor if in case you open that topic. So your professional colleagues, we need to be aware. So as you rightly put it, you have to address the physicians and the ICU anesthetists and all those things. And of course, having a committee in the chat box, I think it is.
They have written one.
Yeah. So organ donation facilitating the committee, so that we will coordinate with you, and any of our IMA doctors need to coordinate, we will go ahead and coordinate with you. My personal suggestion to Dr. Sonal as well as to Dr. Rekha is, let's make a flyer which we will keep, which all of us will utilize in our setups. For example, Dr. Sonal, you will put it as, are you interested? Something very catchy. I think we will discuss about it later, not waste everybody's time here. And even Dr. Rekha, just that some message. For example, I was very much interested in eye donation. but how to do it properly, because I got misguided by many saying that Minto Hospital, it's not done systematically and many eyes are going waste and all those things. Because it's a doctor's forum, I'm talking about it. Otherwise, I don't plan to talk anything negative on a public forum like this. So kindly, both of you, we will coordinate with each of you and kindly give us 2 flyers. So we'll make that flyer, keep it in our IMA house, and we'll put it on our WhatsApp so that this message goes on. It should be very nice. I think we'll talk about it later. Dr. Geeta, you can continue.
Yeah, in the chat box, we have one question to Dr. Rekha. After death of parents, can children donate the eyes of their father? The father may have not pledged his eyes, means father may have not been registered. So can the children donate the eyes of their father after his death?
Yes, they can donate, as pledging is not necessary for donation. Pledging is only to create awareness. When a person pledges, we give them some display cards which they display at home, and their friends see that and they get to know, okay, this person has pledged. That's how. It has nothing to do with donation.
Yeah. Yeah, and without the consent of the relatives, we can't donate also, no? Because yeah, it's very important that that's why the deceased should earlier only tell their children that I am interested in donation. So after his death, maybe the children will take up the cause. Yeah. So can any of the speakers tell us, like, how is this transplantation of human organs and tissue act registration can be done? Because we are in a medical college. So how is that
will help
act
us,
registration test? Yeah, because we have a specular microscope, we have everything in our eye bank, but this license, how it has to be procured?
Actually, you need to register with this one JD ophthalmology. They have a format there about the tissue transplantation for the eye. They have a format, and you just fill it up and you submit it to them. Then they come for the inspection. So that form is available. In case required, I can share the form with you all.
Yes, surely, ma'am. We'll take it from you.
So then you just fill it up and submit it to them with all the requirement, what is required for you as to be recognized as an eye bank. It's a very simple form.
Sure. Ma'am, anybody who needs any advice on this can also email me. My email was mentioned on the.
Yes, sir. I just wanted to say you, sir, give your some contact number so that if you have any problem, we can contact or mail you. Mail will be better, sir, so that we can mail you.
Yeah. So I mean, this is my email. I'm just going to share my screen again, if that's okay. Just so that. Please do drop me an email and I will, and please reach out to me at any time. solartransplantationlabor.com. So because a lot of these registrations go through the Jivasarthakate, which is the allocation, organ allocation body in Karnataka. I'm part of the advisory group there. And if something needs to be facilitated, there are different levels of this. For example, iBank, as Dr. Rekha has already mentioned, if organs have to be donated, there is something called a non-transplant organ retrieval center. These are registrations that can be done on a fairly, sort of an easy way, actually, because things are quite streamlined in terms of the legal aspects of this. And I'm very happy to facilitate this for people who are interested.
Actually, thank you for that, sir. Actually, thank you very much, sir, for taking interest in that or giving us your email ID.
Regarding organ donation, at the iBank, we get a lot of calls. Where do we register our organs for donation?
Right. I think that there is a substantial difference, as you know, between this eye donation and donation after brain death, because we rely on an intact circulatory system, the beating heart.
Yeah.
So, in fact, a lot of well-meaning people do call us as well. That somebody's passed away a few hours ago. Can we use their heart or liver and all that? And then we say that, it's obviously not possible outside the brain death setting. So, but certainly, I mean, all these discussions are opportunities, as we were discussing, because people are well-meaning. People will not think about death until it is occurring to a family member or a loved one. So this is an opportunity, in fact, at that time to communicate clearly And once people realize that it is transparent, there is a process that is very clear, then the public confidence also increases. I think that these are all very small steps, but they have to be done if we have to build up the public confidence.
Thank you both the speakers for your excellent talk. Over to Dr. Anuradha for the vote of thanks.
Yeah, before I start, can I request Dr. Sonal to share a phone number, because not all of us are email friendly, and also Dr. Rekha, one contact number and one email ID.
Okay.
Because it's easier to message or make a phone call than email. Of course, individuals opinion vary. So Dr. Sonal, could you share a phone number?
Yeah, he has put in the chat box.
Yes,
Put in the chat box.
Yes,
Yeah.
yes, I got it.
Yeah.
9686976. Yeah, 37. So that I can share it in WhatsApp. Dr. Rekha?
Yeah, I'm sharing.
Okay.
Rekha madam, you also tell your phone number, madam.
Yeah. I'll share her phone number with you. But now the contact number for the eye donation she is sharing. Whose number is this, Dr. Rekha?
That's my number. I'll share the eye donation number.
Yeah. If you're comfortable taking all messages, no issues.
I'll share the eye donation numbers and the email.
Email also, yes. So before I deliver a vote of thanks, my passion, IMA, I would like to say a few words about IMA. As we all know, IMA is Association of Allopathy Indian Medical Doctors, Pan India. It was founded in Calcutta on 20th of December 1928, and one of the founder member was none other than Dr. B.C. Roy. The intention of starting Indian Medical Association at that time was to promote and advance medical and allied sciences in their different branches, and also to promote improvement of public health and medical education in India. Well, and also to maintain honor and dignity of medical profession. Well, IMA, or Indian Medical Association, is the only representative national voluntary organization of doctors of modern scientific system of medicine, which looks after the interests of doctors as well as well-being of the community at large. So interest of us as well as of the community was the motto with which Indian Medical Organization started. Headquarters, as we all know, is now there at Delhi, and we have 3 lakh plus members there. And in Karnataka, we have only 26,000 doctors out of 1 lakh plus doctors, in the sense that only a part of the total number of doctors in Karnataka are part of Indian Medical Association. And Pan India, we have 1,750 branches. Well, what are the benefits? This is the first question asked by our colleagues when they were approached to become IMA members. What are the benefits of being with IMA is the question asked. Well, single question is, we are going to, well, if that question is asked to me, I will say that to improve our unity, our image, quality of output of our professional services to the society. More important than anything, this is what I say, to protect our fraternity from harassment, overcome financial crisis to family members due to untimely death of the doctor, and help us doctors to smoothly run our establishments without pressure of too many formalities like fire extinguisher and NOC from here, there, everywhere, and all those things, which we are all working at the Karnataka state branch level. Now, coming to the benefits of the schemes that are available with Indian Medical Association, at the national level, we have the National Health Scheme. Then we have National Professional Protection Scheme to protect members and help them in case of harassment, litigation, etc. And at the national level, we also have the National Social Security Scheme. In addition, we have the pension scheme also and the health scheme. So totally, we have almost 5 schemes at the national level. But being in Karnataka, we are privileged because our predecessors at the IMA's Karnataka state branch, they have done a lot of homework for us, and our schemes are excelling compared to other schemes, compared to other states as well as at the national headquarters. Now, what about Karnataka? What extra schemes our Karnataka state branch offers to their members? First and foremost, we have the Karnataka Professional Protection Scheme, KPPS. While earlier, all of us used to, at least earlier me, we used to pay heavy premium for the private insurance for our professional indemnity. Now, KSB is offering 1 crore coverage, irrespective of the branch that we are all practicing. So each doctor in IMA, once you enroll with KPPS, you're going to get coverage for 1 crore rupee. And what is the investment that we make? The first year, each one of us is paying 3,100 rupees. And subsequent years, we need to pay 500 rupees plus overheads, if any. So coming back to the track record of KPPS, we find that there are very few litigations. So proportionately, the share that each one of us is getting is almost nil. For example, this year, all of us have renewed just with 500 rupees, in the sense that we have not had any overheads. So more number of doctors join, proportionately the money that we have to invest, if in case any of our colleagues is in trouble, also considerably is going to come down. That is about KPPS. And coming to the next very important scheme is Karnataka Social Security Scheme. Well, this is a donation scheme where we, in the first year of our enrollment, we pay premium based on our age. So at 59, I had to pay 94,000 plus. That included both old and new scheme. Once you cross 60 years, we are not eligible for this scheme. Even one day you cross, we are not eligible for this scheme. So all doctors who are less than 60 years, we have 2 schemes with KSS, Karnataka Social Security Scheme, and old and new scheme put together based on our age we pay. Coming to our youngsters who are 30, so the total premium will be some 36,000, including both old and new scheme. That is only for the first year. So a lot of our doctors mistake, and we also fail to communicate properly. For the first year, all of us are paying a heavy premium based on our age, and this is a donation money that we are going to put in our account to the scheme as at large. And subsequent years, we are all going to pay, we are going to share the expenditure. So in the doctors who have enrolled in the old scheme, how many of doctors we have lost, and in the new scheme, how many doctors we have lost. So we share the expenditure, and the expenditure usually, at least for the few years that I have, after which I have enrolled now, it's just a few thousands. It will be around 10,000 put both old and new scheme put together. And it is a donation scheme, and it is not a health insurance scheme. So we don't get any of those income tax benefits with this. But as proportionately, when you get this money also, we are not paying any tax on that. And at any point of time, if you are not happy, you can also withdraw. The minor details we can collect later. So what is the advantage of the Social Security scheme is, I as a doctor, if I enroll, if I put my husband as nominee, tomorrow, after my death, my husband gets a lump sum money, usually in terms of around 25-30 lakhs, has gone right up to 80 lakhs, because in the COVID times, our chairperson has announced 1.5 times the regular amount that the nominee gets. So any untimely death of the doctor who was enrolled, the nominee gets the benefit. So this scheme is one thing, I think none of us should fall short of it. And those of our doctors who are already 60, well, we will help other doctors to enroll into the scheme. Now coming to the third scheme that we at KSB have is the KSHS scheme, Karnataka State Health Scheme. Yes, all of us are having private health schemes, health insurance, where we pay very heavy premium. Here in this scheme, as of now, we are providing just 2 lakh rupees coverage. But mind you, it is over and above the amount that over and above the claim that you make with the private insurance. Suppose with the private insurance, you've already had a claim less than 2 lakhs. Let's suppose you claimed for 1.5 lakhs and they offered you 1.3 lakhs. Again, here also you're going to get something nearing to that. That means to say this will be an extra advantage for us. So double claim is possible. Even if we have already insured with the private health insurance, we can still claim up to 2 lakhs from KSHS scheme. And what are the other extra benefits about this is each and every family member, the grandchild, the daughter, daughter-in-law, all of them are eligible. And even if the doctor passes away, those who have enrolled continue to enjoy these benefits, and we are eligible up to the age of 80 years. So I request our doctors to also to utilize this facility. And this is what else I wanted to tell. I think I've covered almost everything that I wanted to tell. Well, I'm very passionate about Indian Medical Association because I want all my fraternity to be under one umbrella, and we need to listen to each other and help our professional colleagues grow. And I don't want any doctor to bend his head in front of a patient. We are all one. And so also our healthcare workers. I also treat them as one, and I don't allow even the Aya to be snubbed or scolded or ill-treated by any patient. Be it rich or poor, she is our professional colleague. At least that is my mentality. So friends, I request all of you not to share any of our professional information with any of your family members who are not doctors. I just don't like my son, who's an orthopedic surgeon, to share his experience with my husband, who's not a doctor. I keep telling him, no, please don't talk. My husband says, so what? No. He is not a professional colleague, and they have no right to listen to what we have to say about our professional experience. We can talk about other things, but certainly not. At least I feel that is the first step that we all have to take, because our information keeps on leaking to others and they misuse. And I feel very ashamed when people tell that we have cuts from laboratories and that we get cuts from the pharmaceutical companies. And I feel very bad because our friends who are there with the Honda or Maruti and all that, every year they go for international tour. And then the paint company person, they send them for trips. That too, not one person, the couple go. And they talk about the peanuts that we all, and I feel this forum, we should not be talking too elaborate on that. I am only insisting on unity. So request each of you to be IMA members if anybody is not. This is only with respect to Dr. Sonal and Dr. Rekha. Others are all IMA members. And I finish my talk about Indian Medical Association. My membership.
Yeah, we'll take one question. One question is there in the chat box. We'll ask the
Dr. Gita, no, I'm not. With respect to all the schemes, I have made a WhatsApp message whom you need to contact for either membership or for any of these 3 schemes. I'm going to circulate it to each and every doctor's group. Thank you. Dr. Gita.
Yeah, one question we have in the chat box. What's the procedure for whole body cadaver for donation for anatomy study? So mainly it is for the medical colleges, the cadaveric donation. Any of the speakers can highlight on this?
Dr. Sonal.
Sorry, I muted myself.
Yeah. What's the procedure for whole body or cadaver for donation for anatomy studies?
Okay, I mean, again, I must say that Karnataka leads most of India in this situation because we have an extremely organized group of voluntary donations. So basically, the most medical colleges do have a format by which people can pledge their bodies for donation, and it has to be signed by the person who's pledging their organs, but obviously the next of kin have to be involved as well. Most of the time, people who pass away because of sort of natural reasons at home, within 4 to 6 hours, the body can be collected from the residents and taken for preservation. Broadly speaking, bodies that are collected are used for 2 reasons. One is for teaching in anatomical halls as is most common in medical colleges. There are certain sets of bodies such as in MS Ramaya, their bodies can be preserved using a special technique such as deep freezing, for example, where they can be used for surgical simulation and surgical teaching. So MS Ramaya has actually got the one of the largest voluntary body donation programs in India actually, and some of these bodies are frozen. They are used for teaching surgeons surgical techniques, laparoscopy, etc. Because these bodies can be frozen at -40, then thawed. At which point the the surgical field is almost like like handling normal tissue. So there are many situations where organ or body donation can be useful. So the discussion can happen with the local medical college. There are certain forms to be filled out, and it is a fairly organized process because people can have, when people pass on naturally after a particular point, people will prefer to have a ceremony at home, after which the body can be handed over to the medical college, where it's taken up for further utilization and for teaching, so that people can be of service even after they pass on.
I think the institution has that right. I think.
Correct.
They have some this application or some type of forms which should be filled by the family members.
Sure.
So after willingness of the family members, we can donate the body.
Correct. So I'll share. I think I had that form which MS Ramaya uses. I will share it with Dr. Anuradha, and then perhaps that will be useful for people.
Or else, if the person is interested before in hand, he can write and keep like my body to be donated to so and so institute after my death, and within activate he can keep
yeah, I mean, I think Dr. Rekha has also pointed this out, because in our country, your will or your body, what you want to do after your body after death is not really a very settled legal question, because by our constitution, the body reverts to the possession of the body reverts to the next of kin. Okay, so basically, when you write something, say you pledge your organs before death, you pledge your eyes before death, or you pledge your body before death, but eventually after death, the question will be asked to your next of kin. Okay, and even if you have pledged while you were living, if your next of kin says no, then nobody is going to actually take the body from you. Okay, so it's important that when the body pledging or any organ pledging happens, then the next of kin are aware. And again, as she has pointed out very clearly, it is more a declaration of your intent that I want to donate my organs after death. And so that people, when they are after say the loved ones passed on, they know what their body, what they actually wanted to do with their body or their organs.
Yes. So it is told that donor card is not a legal entity or an official document. What cards we get, so we can't use them as a legal entity. Only our next kith or kin only can give the consent for donating the organs or the body.
Absolutely right.
Anuradha ma'am, vote of thanks.
Yeah. So sincere thanks to each and every one of you who have logged in late in the night, disturbing your schedule. It could be practice or your family time for me, and practice for quite a lot of others. Sincere thanks to our president, Karnataka State Branch IMA, Dr. Venkatachalapati, then our senior veteran, Dr. Veeranna sir, then Dr. Kumbar had logged in, and our president-elect, Dr. Suresh Kudwa. And sincere thanks to both our speakers, Dr. Sonal as well as Dr. Rekha, for sparing their time. Certainly, we benefited a lot. We did know a few things, and few more things we got to know. And one important message for all of us is, it's not important for me to pledge my organ. I have to make and convince my family members to agree for the same when you are still living, so that they will practice after your death. So that's one important message that I got. Another important link is that both of you are going to get us connected to the respective systems. If in case we need help, we will be able to approach you through IMA for the same reason. Yeah. And then a sincere thanks to our Women Doctors Wing IMA headquarters, Dr. Yashoda ma'am, and also to our South Zone President, Dr. Rajeshwari Amma, and the whole of our Women Doctors Wing team all of us have are very active, and sincere thanks to our chairpersons Savita, as well as co-chairperson Sanjana, and Dr. Geeta Dopa on the other side, and then Dr. Soumya is there, and many more of us in Women's Wing. We are we are very active. One word. And then sincere thanks to everyone who has logged in. To name a few, Dr. Surendra is there, then Dr. Ramesh Raheja, Dr. Ratan Kumar, and Dr. Ansuya also are women doctors wing.
Dr. Veena Bhatt.
Bangalore, Dr. Veena Bhatt, then Captain Prabhakar. Sorry, I'm not going to read everybody's name because that's going to disturb everybody unnecessarily. And last but not the least, sincere thanks to our web manager, Mr. John. Though his laptop broke down, he rushed, got it repaired, and is back again. A sincere thanks to him for promptly helping us out with the link and helping us record. So again, hopefully this is recorded so that we can share the link for those of us who would like to review again, as well as for those who have not been able to log in. Thanks everyone, and in particular, a sincere thanks to Dr. Sonal and to Dr. Rekha. And now we are all of you are logging out except the Women Doctors Wing team. We have a small meeting. Thank you very much.
Thank you.
Thank you so much.
Thank you. Yeah. Thank you, Dr. Sonal and Dr. Rekha, ma'am.
Thank you, ma'am.
Thank you, Dr. Sonal and Dr. Rekha, ma'am.
Thank you so much for having us. Bye.
Thank you. Bye.
Thank you. Soumya, please be there.
Yeah, I'm there.
We are going to discuss regarding our conference, which is going to be shortly.
Sure.
Ma'am, wait, let everyone leaves, then we'll talk.
Yeah.
Well, if we have an option of deleting them, we will start.
Yes, we can do, I think.
John, idira niva?
I don't think so. John is there.
No, Sanjana is only made co-host. Ade tagilike.
Please.
Yeah. Thank you everyone for joining. So now we are just having a small meeting of our Women Doctors Wing. So I think.
Shantu, idu yenada? Request everyone who are not in Women's Doctor Wing to log out, please. ಒಬ್ರಿಗೊಬ್ರಿಗೂ ತೆಗೆದು ಕಷ್ಟ ಆಗ್ತದ ಮ್ಯಾಮ್.
ಅದೇ.
If they log out, then it will be good for us.
Yeah.
Two are there. That's all. Two.
Yeah, two.
Nodi ma'am, I am removing them. You just see.
Yeah.
ಮತ್ತೆ ಯಾರಿದ್ದಾರೆ ಮ್ಯಾಮ್?
The next I'll tell you. My PG only. I'll tell. Yeah,
ಆಯ್ತಮ್ಮ. ನಿಖಿಲ್ ಪರಮೇಶ್ ಮೇಡಮ್.
ಅದು ಇವರು ಮೇಡಮ್ ಅನುರಾಧ ಮ್ಯಾಮ್. ಅದು ಅನುರಾಧ ಮೇಡಮ್ ಎರಡೆರಡು ಉಂಟು ನಿಮ್ದು?
ಎರಡಿದಾವೆ ಮ್ಯಾಮ್.
ತೆಗಿತೇನೆ ಇವಾಗ.
ಎರಡಿಟ್ಟಾರ ಮೇಡಮ್. ಮಾಡ್ಬಿಟ್ರೆ 1 2 3 4 4 ಜನ ಇದ್ದೀವಿ.
ಇವರು ಸೌಮ್ಯ, ಅನಿತಾ ಡಿ ಫ್ರೀ ಇಲ್ವಾ? ಸವಿತಾ ನೀವು ಮ್ಯೂಟ್ ಮಾಡಿದ್ದೀರಾ?
ಇವರು ನಮ್ದು
ಅನಿತಾ ಲಾಗಿನ್
ಸುನೀತಾ.
ಅನಿತಾ ಲಾಗಿನ್ ಆಗ್ತಾರೆ. ಸುನೀತಾಂಗೆ ಕಾಲ್ ಮಾಡಿದೆ, ಅವರು ಇದ್ ಮಾಡ್ಲಿಲ್ಲ, ರೆಸ್ಪಾಂಡ್ ಮಾಡ್ಲಿಲ್ಲ. ಒಂದ್ಸತಿ ಸೌಮ್ಯಂಗೆ ಇರಕ್ ಹೇಳ್ಬೇಕಾಗಿತ್ತು. ಹೇಳ್ದೆ
ಮೇಡಮ್ ಹೇಳಿದ್ರು. ಅನುರಾಧ ಮೇಡಮ್ said like
I'll talk to her.
To call her once, please.
Yeah.
ಇರ್ಲಿ ಬಿಡಿ, ಮಾತಾಡ್ಬಿಡಿ. ಎಷ್ಟು ಜನ ಇದ್ದೀವಿ ಅಷ್ಟೇ.
ಅನಿತಾ ಲಾಗಿನ್ ಆಗ್ತಾರಂತೆ.
ಅನಿತಾ ಆಗ್ತಾ ಇದ್ದಾರೆ. She is logging in.
ಆಯ್ತು ಬಿಡಿ ಮೇಡಮ್ ಮಾತಾಡಿ. ಅನುರಾಧ ಮೇಡಮ್ ಹೊಸ
Yeah, we'll have-
ಮ್ಯಾಮ್ ಡ್ಯೂಟಿಗೆ ಹೋಗ್ಬೇಕು ಮ್ಯಾಮ್. ಕೇಸ್ ಇದಾವೆ 2-3.